Ready? Yeah. Hello and welcome to today's teaching. Today we have Dr. Katrina Forsyth, who is a F2 doctor based at St Thomas's Hospital in London, and she is going to be discussing common conditions in vascular surgery that a junior doctor may encounter. Over to you.
Perfect, thank you and welcome. And this evening, hopefully not too hot where you are. So we're going to get started on common conditions, and next week we've got another series on emergencies. So there will be some things that we miss out today just because I don't want to duplicate that. Okay, so hopefully this will start moving for you. So just a quick overview of what we're going to do today. I'm going to go quickly over the common investigations. Often there's a few investigations that I think as a junior, I personally got a little bit confused about, for instance, like the difference between Doppler and DUPLEX, and then things that I think is expected of you as a junior, so it would be useful for you to know. And then we'll just briefly go through the conditions that I think you're going to come across the most. Okay, so quickly looking at some investigations. So I think important things that I found when I'm seeing a patient is to kind of clarify in my mind a way of going about it in a logical manner. And I know that a lot of seniors will like you to organise your thought process and how you communicate them in that way. I found it quite useful to do something called bedside bloods, imaging and special tests. I know in the UK that's often how you're taught for ski examinations in final year. So often, you know, if you're seeing a patient on the ward as part of the ward round anyway during your normal day, you're going to be doing things like doing a cardiovascular exam, an abdominal exam, for instance. Obviously in vascular, the kind of areas that you want to focus on is making sure that you're doing a peripheral vascular exam. So I would recommend reading up on that if you haven't done that recently. Ensure you've got an ECG for your patients as a baseline, and you should be able to get that very easy on the ward anyway. Often the vascular patients are very complicated patients from a comorbidity point of view. So you really want to have that baseline ECG, because when you're called in the evening, when you're on call about a chest pain, you want to have something to compare to. And then ABPI, I'll go into that in a little bit more on the next slide, but ABPI is very, very useful. You've got a lot of your patients are going to be ulcer patients, and a lot of them are arterial patients, so vascular paths. So really it's quite useful to know how to do that. And essentially it's quite simple. You're taking a blood pressure cuff and you're taking the femoral systolic pressure, so the leg systolic pressure. It's normally done at the ankle, but I know some seniors do it at the thigh, and you're going to divide that by your brachial systolic pressure. And then you're looking then at that ratio to see what the number is. Essentially, if it's greater than 1, that's often in diabetic patients that have got calcified vessels. If it's less than 1, then that's abnormal and there's a reduced flow. And we'll go into those breakdown in a minute. A handheld Doppler, I've got a picture for you on the next slide. I don't know if you guys have seen that before. That's really useful. If you're going on a vascular ward round, you will often have one of those with you, or your reg might carry it. Essentially, you're using that to get a sound when you're placing it on a vessel to hear whether or not there's good flow through that vessel. So it's a very good quick indicator of whether or not someone's got good pulses. Bloods, there's a varied myriad here that I put down. Obviously it depends on the condition you're looking at, but remember, if you've got a patient that's going for surgery, or it's a patient that's expected to lose some blood, ensure you've got a valid group and save. That's often missed and can cause a lot of frustration with seniors, because often, depending on the hospital, it might only be valid for 2 days, 3 days. If your patient hasn't had blood, it might be valid for a week. And again, depending on the hospital, you might need to have 2 valid samples in the laboratory, or if they've got an electronic system, you might need 1. So just clarify that when you start, just so that you don't get into any trouble when you're on call. Lactate, really important. You can get that on a VBG. So think about different ways you can get that kind of a skill really in the evenings when you're on call. You don't want to be sending a formal blood test that's going to take hours to get back without getting a marker right there and then if you're worried about someone. So to get a VBG to get that lactate. And then obviously looking at the other comorbidities by getting other blood tests there. Imaging, Not all of your patients are going to need an echocardiogram, but if they have cardiovascular risk factors, your consultant or registrar might think it's appropriate, and equally anaesthetics might think it's appropriate. You want to have a good idea of how well their heart is functioning so that you're not putting them under undue pressure. Equally, if you've got a patient who's got terrible renal function, which is often the case with these comorbid patients, you're going to get into a bit of a tricky water where you're trying to offload them from a heart failure point of view, potentially, but their kidneys might not be too happy about you drying them out. And that's often the case when you're the junior on the ward, is trying to find that balance of how much furosemide, how much fluid. So if you can get an echo on those patients, that's a good thing to do early, and it will help you out because you can alter the amount of fluid you're giving and how much you're drying them out. Remember that if you're giving a patient a bolus, if they're unwell on the ward, if you've got someone who's got raging heart failure, you're going to want to go at a lower level. So giving them, say, 250 ml bolus rather than giving them 1 litre over 1 hour, because you might get yourself into trouble then having issues with pulmonary edema. Okay, there's some more specific scans here, MRIs. MRI cardiac perfusion is normally requested by cardiology, but you're going to be working with them a lot if you're working on a vascular firm. So that might be something just to not know a lot about, but maybe perhaps read up a little bit so that when you're getting those reports back that you have a baseline understanding. And that's looking really essentially at whether or not the coronary arteries are supplying the heart very well. As far as most of the investigations you're going to be requesting and looking at, often they're the DUPLEX scans. So whether that's an arterial phase or a venous phase, and that's using the ultrasound to actually look at not only the area, that's what's different about DUPLEX. You can look at the muscle or the structures around the vessel, but then you're also looking at the flow within the vessel. So having that combination is often what you need to diagnose arterial and venous conditions. And then CT angios are often what's needed to plan surgical intervention, so after the DUPLEX, because you want to look at all of the structures around. Now, a CT angio needs contrast, so you need quite good renal function, really. And often your patients don't have great renal function because they're vascular paths. Sometimes you can get away with doing an MRI angiography instead, but that's something you need to have a chat with radiology about, because the MRI won't need the contrast. Okay, so moving on, so we've talked about all of the investigations. Let's put them into a little bit of practice here on a practical level. So Doppler duplex, I've mentioned a little bit. A Doppler gives you the sound waves of the pulses. So you can place it, for instance, on your radial artery or the posterior tibial, whatever you're looking at and you're concerned about. So that's really useful as a bedside test if you're concerned about an emergency, perhaps a critical limb ischemia. And then the duplex is what you're going to get investigated and done in the vascular lab, which is a trained radiographer then doing the scan, the ultrasound scan with a Doppler. What's good about a handheld Doppler, so that's what's on the bottom left of the screen here, you can see, is they'll talk about having monophasic, biphasic and triphasic flows. Essentially, that's, if you look at the graph on the right hand side, you essentially, when you've got a normal flow, it should be triphasic. So during systole, you get that big up wave, and then during kind of the lag afterwards, you'll get a reduction going down, and then you should get kind of negative level here. You can see a little dip below the baseline there, and it should come back up. And that coming back up part is the elasticity of your vessels squeezing. So if you have damage within your arterial system or your venous system, you won't get that bounce back because your elasticity is lost. That often happens with aging anyway. So as you get older, you might see a more biphasic, that's what it will be recorded as, pattern. Or if someone doesn't have a very good arterial supply, it might be monophasic or not there at all, which means that you're only really getting flow during systole, or you're not getting flow at all. So that's what that means, and that's quite useful to understand when you see it written down. Just a little element here, just to have a read later on about Doppler effect. Essentially, the frequency that you're going to hear is higher if it's coming towards you. So if the flow is towards you, and the frequency will be lower if the flow is away from you. That's just more of a nuance for you to understand. Okay, and that's just a recap. So hopefully you can get these slides afterwards or have a look on YouTube and go through it. Okay, ABPI, as I've suggested, greater than 1, that's normally diabetics or people with calcified vessels. Less than 1, you're concerned about potentially there being a lack of pressure. So whether that be peripheral artery disease that's between a level of, you can see here on this diagram, 0.8 and 1, which means often these people will complain about walking a certain distance and then getting calf cramp and claudication pain. And then if it gets lower, that pain is not just when they're walking a certain distance, they will start to get at rest. And if you're starting to get rest pain, you're concerned about moderate or severe occlusion at that point. And once it gets less, well, 0.4 really is the cutoff. That for us is a sign of critical limb ischemia, and that becomes an emergency. And just remember the leg pressure, systolic pressure of the arm systolic pressure. Okay, this is just a reminder to you, because we don't have time to go through all of this in detail. Just have a quick read of an anatomy textbook. Your surgical colleagues will often ask you about the anatomy, especially if you're going to theatre and if you're keen to do surgery as a career. There's specific nuances, for instance, the axillary artery, the branches, and when it becomes the axillary artery from the brachial artery, and little cut-offs like that. So I would just reminder for you to have a look over that, and the branches, especially from the descending aorta, if you're going into more mesenteric ischemia sort of problems. Okay, so common arterial conditions. We'll whiz through this very quickly because I know we've got limited time this evening. So we're going to talk about ischemias, we're going to talk about aneurysms, and then we're going to talk about obstructions. So issues within the vessel, issues with the vessel itself, the wall, and then issues coming from the outside obstructing, and that's often how surgeons will discuss things. So chronic limb ischemia. Often that you'll find the presentation goes something like this. A 55-year-old male presents with pain in both calves walking 50 yards. And then you notice in your examination that he's got no femoral pulses or no distal pulses. And what you'll be asked is, what investigation do you want, doctor? And is this chronic or is it acute? Now, the nuances when you get this presentation between an acute and a chronic, if you've got sudden onset arterial occlusion, which is the case with the acute limb ischemia, you're going to have the Ps, which we'll go into in our emergency, but essentially a pain pulseless, paresthesia, a very cold, often it's a leg, but it could be an arm. Now, this is not so much the presentation in this case. This is someone who's had what describes as claudication, really. And then you've noticed they've got a lack of pulses distally. If they have a lack of proximal pulses in a limb, say a femoral pulse, the reason that's important in this scenario is because it changes the investigations you're going to do. But this is not an acute limb ischemia because they've not come in with a cold pulseless leg. This is something that's been going on for some time, so it's more chronic. Now, just a quick overview, peripheral arterial disease. Most often it is an atherosclerosis causing this, but you obviously can get emboli and other things going on that are thrown off that cause issues. And emboli normally causes an acute limb ischemia. In this case, with a build-up over time, chronic, it's normally atherosclerosis. What you can see down the bottom here is the nuance. If someone has a femoral pulse when they present with like a claudication type history, you can do an arterial duplex, which is that ultrasound scan that we spoke about earlier that shows the flow, but the structure is also around it. That is different if someone comes in with no femoral pulse, because to get that imaging above the issue, which is what you want, you can't really do that with an ultrasound. There's bony structures. If you think about how the femoral artery descends into the leg, the ultrasound is not really a good way of going about getting that. So actually you want to get a CT angiogram. And often that's what we end up doing anyway when we're planning surgery, because you're trying to plan whether or not there's something you can actually remove, whether or not you need to do open surgery, or whether you need to get IR involved. So remember, If there's pulses, then you can get a duplex. If there's femoral pulses, if there's no femoral pulses, you need to get a CT angio. So you get to skip a step. Okay, and then we'll move on. So chronic limb ischemia, this kind of goes on what we've just been speaking about. Have a look at this in your own time, but essentially this presentation of claudication, which is going to become worse if it's untreated. So it'll become a shorter distance that they can walk, that they're getting pain in their calves and their legs, can be classified by the Rutherford classification. And you can see there's two different classification systems that people will use here, and it depends essentially how far they can walk before they get claudication. You will say whether or not it's moderate, severe. That's quite vague, really. Make sure when you're clerking the patient, you get a distance from them. It might be easy to say to them, can you get to the bathroom? Do you leave the house? Those sort of things are really important, and especially to anaesthetics, who can make a judgment of how well they are. It tends to be intermittent. If it's intermittent claudication and it's chronic, we tend to give 6 months of physiotherapy. And that in itself can often work alone. So you don't need to do anything else. There's no surgery needed. If, however, they're presenting with a more severe claudication picture, so a shorter distance that they can walk, that might mean that they need to have surgical procedures done. In these patients, when they've got some distance in them, you need to optimize their cardiac comorbidities. And as a junior, often you're the one left on the ward to do that. So ensure that you know your diabetic management, ensure that you know how to control blood pressure, ensure that you've got people on statins that can tolerate them and things like that. Okay, this again, something for you to look at in your own time, but there's something called Berger's test, which essentially you can test how bad someone's ischemia is by getting them to raise their leg. You'll find a degree at which it will go pale. And then if that's a very low degree, so they can only lift their leg partly before it goes pale, that's quite bad. Obviously, if they can go fully to 90 degrees and their leg is fine and it isn't going pale, then that's not a concern. You won't see that often done much on the ward, but it's a very useful test and is often done in clinic. Okay, and then this diagram on the right-hand side just shows you where lesions are, essentially showing you that if you've got a very short lesion, so a very short area of atherosclerosis, that gives you more realm to get IR involved to do treatment if they've got quite severe symptoms. If you've got a longer area of atherosclerosis plaque, then you're limited because you're trying to then open up with angioplasty with a balloon that whole area. Okay, moving on. Chronic mesenteric ischemia. Now, this is something that's not too common, but I want you to remember it in the back of your mind when you're seeing a patient that comes in with grumbling abdominal pain and they've gone off their food, because this one's missed, and it could get you in a bit of trouble if you miss it. Essentially, these are vasculopathic patients that come in and they've just got grumbling abdominal pain. You might see it on patients on the ward, which is another reason to think about this if you're reviewing them and they're in for another reason and they've suddenly developed abdominal pain. Essentially, they've got atherosclerosis within the vessels supplying the bowel itself. It's not an emboli, so it's not an acute mesenteric ischemia, but it's the same problem as the peripheral vascular disease that we just spoke about, but it's happening in the vessels that are supplying the gut itself. Often, they won't present until the celiac, the SMA, and the IMA are affected. At that point, obviously, that's a lot of atherosclerosis, and we often need to manage that from a medical point of view as well. Can we lower their cholesterol and things like that? Okay, aneurysms. So aneurysms, you need to group them into two areas. You've got true aneurysms, which hopefully you all know. It means all 3 layers of a vessel wall have an outpouching, essentially, a bit like a balloon. Whereas a false aneurysm is often when you've got a break in one of those areas, and then you get the blood kind of pushes out rather than all 3 layers themselves. You can get your AAAs and problems there with rupturing, and that we will go into more in the emergency lecture next week, but I just want you to be aware of these peripheral and visceral ones, because These don't tend to rupture very frequently and are more insidious and more likely to be your elective patients or those that are on the ward that will have this as an incidental finding. And I say incidental deliberately here because most of these patients, you're going to get a CT scan that suddenly has a report that they've got an aneurysm. They might not necessarily have symptoms, but it doesn't mean that we don't need to be aware of it and treat it. If they're symptomatic, then you need to start thinking about whether surgery is an option. That is unusual. What you need to remember that is if you have a patient coming in with an abdominal aortic aneurysm, there is quite a high chance that they've got a popliteal aneurysm. But actually, if you've got someone with a popliteal aneurysm, you've got an even higher chance of them having an abdominal aortic aneurysm. Okay. So make sure you're screening those patients if you find one. Now, you can do an ultrasound duplex scan as a follow-up with these patients. Because they're unlikely to rupture, it's quite rare, we can give them medical management and do follow-up serial scans. If they are symptomatic, then you can do a CT angiography or an MRI angiography if they're your kidney patients or your young patients and you don't want to subject them to the contrast or the CT scan. Okay, so if you look at this image on the top here, you can see a bulging area. That is a popliteal aneurysm. The image below it is the surgical kind of diagram of what they would do if they wanted to do an intervention. So if someone's very symptomatic, you open that popliteal area and then essentially you are cross-clamping above and below and using heparin within the vessel to stop that throwing off clots, because obviously if you're in an area with atherosclerosis and you're moving it about, there's a chance you create an emboli. They can then take that area out, replace it with a graft, and whether that is the veins that they then use, you can use a graft from the body itself, or whether or not that's a plastic graft. That sort of depends on the surgeon and what's available in the patient. What you've got here on the right hand side of the screen is a nasty looking foot. That's trash foot. That's if emboli get thrown off, you then get these clots and you end up with necrotic toes. So just be aware that's what you're looking for if things go wrong, really. And you can get thrombosis within these aneurysms if you don't do anything, and it does throw off those emboli and causes trash foot. Okay, so EVAR, hopefully you're aware of this. So endovascular arterial repairs. Often IR will do this for you. They'll go in and do an angioplasty. So they'll make an entrance in the femoral artery or the radial artery, put a guide wire up and add in a little stent, which is like a little metal mesh tubing that they blow up with a balloon inside the vessel. They will then essentially create a pathway with your aneurysm going around it, but the aneurysm no longer has the blood flow going through it, so it doesn't expand, and you're then reducing the risk of rupture. You do have things called endoleaks. Have a read of that in your own time. That's just a risk if you go for the IR procedure. But yeah, very infrequently you'll see an open repair for this. This is very rare at aneurysms, but just be aware you can get them anywhere in the body, in any organs and the blood vessels that supply them, and often they will come in with a vague abdominal pain and you will get a CT abdo-pelvis and then this will be found. Unless it's causing an anatomical issue or it looks like it's going to rupture or it has ruptured, you often don't do much other than surveillance. Okay, pseudoaneurysm. Often, after you've asked for your lovely interventional radiology colleagues to do a procedure, you'll have a patient on the ward that comes up that has a bulge. And you think, oh no, could this be a hernia? And so you go and examine it. And actually what's happened in these patients is you've created a false aneurysm. So by putting in the metal wire itself, you've created a break within that vessel wall and you get a bulging area. You can get that in IV drug users as well because they're creating a false passage into the vessel. Often you can do compression over that area to resolve it, and they will use ultrasound to do that. However, in some people, there's a risk that you're going to create a thrombosis in that area and then have the problems like trash foot that we just spoke about. So that's quite a high in-depth conversation between your seniors, really, to decide whether or not they're going to break down clots or whether they just do an open repair. They won't go back often with interventional radiology in this area because that's often what has caused the issue in the first place. Okay, so moving on, hopefully, thoracic outlet syndrome. So this is moving on to the areas of things compressing from the outside of a vessel. So if you have a patient that presents via A&E, having had compression within the neck, you can imagine, because of the structures which are in the neck, as in this diagram, you could have neurovascular compromise of the arm, you could have arterial compromise of the arm, or you could have venous compromise of the arm. So if it's the neurological, so your nerves that are being impinged, that's going to give you paresthesia, it's going to cause pins and needles, weakness in the arm, potentially wasting of the muscles in the arm. If it's vascular, it presents very similar to a arterial occlusion. So they're going to have problems with a cold arm, a pale arm if it's arterial, weak pulses, especially when you've got a certain position which is causing the compression to become worse because of the nature of how the shoulder works. Essentially, you look for that. You do a good neurovascular examination of the limb. The things that cause it, often it can be a cervical rib, so an extra rib that's causing pressure on this area. You can find that out on a chest x-ray. Potentially is other things like tumours and cysts. And you can imagine if you've got a tumour in this area, it's going to cause quite global effects if it's pushing down that brachial area. You can essentially have a surgeon go in and they're trying to release the pressure on that area. If it's a clot or problems that are causing symptoms lower down, they can do localized problem solving. So essentially thrombolysis in that area if it's the clot that's causing it. But to relieve this pressure up here, they can do something called an anterior scalionectomy. A muscle in your neck here can be divided and relieve that pressure. They can go underneath the axilla as an approach, or they can go at the front for an approach for that. Okay, subclavian still, be aware of it. You're probably not going to see it. It's very rare. However, essentially you've got a blockage in one of your subclavians. Often it's the left one, and your body copes and adapts by getting a collateral supply. And that collateral supply is essentially, if this side is blocked, you're going to get a collateral coming around from your other vertebral artery, having retrograde flow to bypass it to then supply the limb that's got a blockage there. Often it's the left-hand side, often it's males that present like this. And you can get a duplex scan to see the blockage because it's in the limb, it's a little bit easier. Often they'll get a CT angiogram with an aortic arch component to that scan as well. And then you have the debate of how well the patient is to do surgery. Venous, will quickly fly through this, I'm aware of the time. So varicose veins, very, very common. What I want to draw your attention to is this table I've created on the right-hand side. Now, NHS and NICE funds, obviously, certain procedures. Lots of people have varicose veins. Often they'll come because they don't like how they look. That no longer suffices meeting our criteria for us to do intervention on it. So that's what that first section is. I mean, obviously, patients can go privately, but you're not going to see people because they've got a nasty looking vein. If they're in the NHS coming with that problem, it's often because it's causing them issues with symptomatic issues. So whether they've got a complication from having it, whether they've got a deep vein thrombosis, whether they've got vascular changes within the leg, so venous insufficiency within the leg, lots of swelling and issues with mobilizing. That's really when we start to think about surgery. The first line surgery for varicose veins is going to be endothermal within the NHS before thinking about something called sclerotherapy, which is essentially using foam in that area. Endothermal, your vascular colleagues, the surgeons will go in at a lower part of the leg. Often this is the great saphenous vein that's affected, and they will essentially use a laser to burn the inside and close it, so like a diathermy, to stop that being a problem. Now, you can imagine if you're doing a big operation on someone's superficial venous system, you're then hoping that their deep venous system can then work and do all that work on its own for the venous supply to that limb. So you would then have to check that that deep venous system before you go and do this surgery is intact. And if a patient has a big clot, so a deep vein thrombosis, you can't then remove their superficial system that's helping them get around that clot, essentially. Just be aware that there's a classification. If you're seeing this, you might just want to have a quick search of this and be aware of it if you're coping with these patients on the ward. Often they're incompetence within the valves, so they're not closing the valves in the legs that causes this. And that's 98% of these patients. Some of these patients, the veins, it's because you've got a pressure, so a mass, whether in women that can be a gynecological mass, whether that's like fibroids, a uterine mass like a cancer or something, putting pressure down and causing backflow. In patients where you do a venous duplex and you think that there is deep vein problems, you then might end up getting CTs of the pelvis, for instance, to rule out those other problems. Chronic venous insufficiency, that's the symptoms that you're going to get when you don't have good venous drainage of a leg. You get venous stasis, so you have all of the hemosiderin, sort of that brown discoloration and scarring you see in patients that come in, they've got brown lower legs. These patients then get dry, they get some swelling, and then they become at risk of having venous ulcers, which are quite nasty. Those ulcers are painless, but they can get infected, and then you might end up doing amputations. So that's why it's important to treat these patients. You can do a Trendelenburg test, which is essentially a tourniquet, where you're checking how good the you compare the deep and the superficial system by adding a tourniquet, releasing it, and then seeing whether or not the flow comes back. I've got some links at the end, some videos, which I think would be useful to look at, just the practicalities of that in a patient. And the last bit to go over, ulcers. Now, ulcers, as far as common conditions, this is going to be your mainstay. Unfortunately, the vascular wards tend to be quite smelly wards for a reason, and it's often the ulcers that are culprits there. Most of them are venous, so we've been talking about venous insufficiency, so let's start with that. You have a back pressure for whatever reason, whether that's the valves not closing, whether that's the mass causing the back pressure, and then that causes the swelling, the ulcers, eczema, it becomes itchy and the skin changes. You can do the Doppler ultrasound bedside, and then you're probably going to end up getting a duplex in those patients that come in to check where the blockages are, whether or not that's amenable to getting IR to do angioplasty, or whether that's amenable for surgical intervention. So you could get a graft to get around blockages, or whether or not you can do bypasses. So you're essentially just using the normal anatomy and creating another connection to bypass areas that are kind of broken. I think arterial ones, just have a look, they're more painful, and neuropathic, they're mainly your diabetic patients. Margins are exceptionally rare, but just be aware of them. And I think that's it for me, time-wise. If you can, I'd be really grateful if you scan a QR code and give us some feedback, and I hope to see you all next week. Hopefully that's okay.
Any questions? Okay.
Thank you. All right, have a good night, everyone.
So Katrina, we've been asking all of our teachers if they could give one piece of advice to a new F1 doctor, what would you say?
Yeah. Don't be scared of asking the nurses. Often they've been on the ward for years and they know all the secrets. And that's often how I've got myself out of a lot of trouble, actually.
I agree very much. All right. Thank you for joining. We'll see you all next week for the vascular surgery teaching, and tomorrow for, I think it's the orthopedic teaching. Either way, just keep an eye on the Instagram accounts and we'll go from there.